Hi, everyone, and welcome to Empowering Yourself at Home, Proactive Women's Health Practice. Join New York City's leading top doctors in cancer, genetics, and women's health from Mount Sinai Hospital, RMA of New York, and T.E.A.L, which is short for Tell Every Amazing Lady, for an interactive webinar. Empower yourself with ways to care for yourself at your health at home, including vital cancer screenings. Today, we're going to spend some time having questions answered about genetics, treatment options, and more. We're going to have a casual Q&A with two of our top New York City doctors and try to answer as many questions as we can. So if you have any questions, please use the chat box throughout this presentation, and we'll get to as many as we possibly can. I'll be moderating today's event. My name is Pamela Esposito-Amory, and I am the CEO and co-founder of Tell Every Amazing Lady About Ovarian Cancer, Louisa M. McGregor Ovarian Cancer Foundation. We're also known simply as T.E.A.L. I know that was a long name. We're also known as Tell Every Amazing Lady. The reason for that name is teal is the color that symbolizes ovarian cancer, just like pink symbolizes breast cancer. We're a Brooklyn-based foundation with resources available to women throughout the country. We provide free services to all ovarian cancer patients, survivors, and anyone who's ever been diagnosed with ovarian cancer. We also provide support to their caregivers. We offer free resources all year long, like wellness workshops, art therapy, support groups, clinical trial navigation, and more. And this is just a reminder, we'll talk more about this later, but there's no accurate screening test for ovarian cancer, and that's why Tell Every Amazing Lady was started. We know that knowledge of ovarian cancer signs and symptoms are crucial in saving lives for this disease. Not every amazing lady knows this important information, sometimes due to racial and socioeconomic factors. T.E.A.L raises awareness about ovarian cancer in underserved communities through lectures, schools, health fairs, hospitals, community centers, and so much more. Now it's my pleasure to introduce these two amazing doctors joining us today. I'll tell you their bios first, and then we'll get started with some questions. So first joining us is Dr. Stephanie Blank. She is Director of Gynecologic Oncology for the Mount Sinai Health System and a professor in the development of obstetrics, gynecology, and reproductive science at the Icahn School of Medicine at Mount Sinai. She's also the Director of Women's Cancer Program at Blavnik Family Chelsea Medical Center at Mount Sinai and Director of Oncology Programs. The Blavnik Family Women's Health Research Institute. Dr. Blank specialized in treating patients with gynecologic cancers, including ovarian, fallopian, peritoneal, uterine, cervical, and caring for women who are also at risk for cancer. Dr. Blank has conducted extensive research on women's health by serving on many boards. She's involved in the Ovarian Cancer Committee of the NRG. She's involved in the development of NCI-sponsored practice changing clinical trials, and she's been a principal investigator for multiple clinical trials. She also collaborates with other researchers in the Tisch Cancer Institute. She has been broadly published in peer-reviewed journals and textbooks, she frequently presents at national and international conferences on women's gynecologic oncology issues. She's a recipient of many honors and awards, including Castle Connolly Top Doctors, Council of Resident Education in Obstetrics, Gynecology Teaching Award, among others. Dr. Blank earned her medical degree from the University of California, San Diego School of Medicine. She completed her residency in obstetrics gynecology and New York Hospital Cornell Medical Center, and a fellowship in gynecology oncology at University of Pennsylvania Medical Center. Dr. Matthew Letterman is a board-certified reproductive endocrinologist and infertility specialist, and is often acknowledged for his compassionate care, devotion to patients, and his clinical expertise. He treats patients in New York City at the RMA of New York West Side location, as well as in RMA Westchester office in White Plains. Prior to joining RMA of New York in 2014, Dr. Letterman treated patients at the Continuum Reproductive Center at St. Luke's Roosevelt Hospital. After graduating from the University of Michigan, Dr. Letterman received his medical degree from Chicago Medicine School, completed his residency in obstetrics and gynecology, as well as his fellowship in reproductive endocrinology and infertility at the Albert Einstein College of Medicine, Montefiore Medical Center. During his residency, he served as administrative chief resident and also received the Albert Einstein College of Medicine at Yeshiva University Teaching Award 2 years in a row. While in fellowship, Dr. Letterman was acknowledged by the Endocrine Society for his research and received a travel grant. He served on the medical advisory board of FORCE, Facing Our Risk, Tell Every Amazing Lady, and is a fellow of the American College of Obstetricians and Gynecologists. He's a member of the American Society for Reproductive Medicine, Society of Reproductive Endocrinology and Infertility, Endocrine Society Westchester, OBGYN Society, and Resolve. He's also named to the list of super doctors featured in New York Times Magazine consistently since 2015 and Castle Connolly Top Doctors since 2019. He's America's Most Honored Doctors in 2020. He's published scientific abstracts and articles in peer-reviewed journals, fields of endocrinology and infertility. So both of these doctors are absolutely amazing and have incredible credentials, and they're here today to answer a lot of your questions. So I welcome Dr. Blank and Dr. Letterman. Welcome today, and thank you for joining us with all of your amazing skills. I'm going to kick this off with the first question for both of you that seems to be on a lot of people's minds. In this, we're starting to come to the end, hopefully, of this pandemic, but what is it like to go to the doctor's office for anybody these days? Can you kind of walk us through, each of you, what you've been experiencing?
Sure. I'll start, and thank you, Pamela, for that long introduction. Embarrassing. I appreciate it. Thank you so much. So going to the doctor now, we've taken so many measures really to keep you safe. So a really important part of that is maintaining social distancing. So, for example, in our waiting room, we literally took a tape measure to make sure that we have fewer chairs in the waiting room, but actually the waiting rooms are not full because we are booking many fewer patients. We're doing a lot of visits via telehealth. If we used to see a certain number of patients in the hour, it's probably half that number in person and then maybe one telehealth visit in there. You will get a call before you come to the doctor to make sure you have no symptoms. You'll get a temperature check at the door, and you'll also be asked again if you have any symptoms. We're not using every room that we have. Everyone's wearing masks. Things like the communal coffee station, we're not doing that anymore right now. Maybe that'll come back, but maybe not, I'm not sure. Couple other things, we're really trying to minimize the number of trips that any patient has to make. So let's say you need to go to the doctor, you need to get a blood draw, you need to get a scan. We try to coordinate everything so you just have to come once. We know that people are nervous, so we're really aware of that. Some of the things we're doing are exactly the same. We've always been sterilizing the rooms, for example, but now once we sterilize the room, we put a sign on the door that says this room has been sterilized. We're just trying to do a lot to keep people, let people know that we're aware of this situation.
Great. And Dr. Letterman?
Yeah, so we're actually doing a lot of similar stuff in our office. Just taking a step back, when we were in the height of the pandemic, we actually paused our IVF treatments for a little while until we came up with a plan to try and make it safe for our patients and for our staff. And so we actually put a pause, and we've been actually kicked back up our IVF in a much different way starting the end of May. And we're doing a lot of similar things in the office where our waiting room is very different. Where there used to be tons of chairs, they're all spread apart. They were all measured, so it kind of looks funny. It looks like a lot of dead space, but it's there for a reason. And our patients and our staff, everyone's wearing a mask. We're taking the temperatures, and probably one of the biggest changes. So anyone who's doing fertility treatment, the busy times in the morning. So our office opens up anywhere from 7 to 9:30. And we have multiple offices, and that's where patients who are doing IVF, IUI cycles, they come in for the bloods and ultrasounds. And it used to be the waiting room was full, it was busy. The quick visits in and out of the office were very efficient, but it'd be a full waiting room. Now what we've done is all these patients are getting a time slot. So they're getting a time slot, and then before they come up, they get a text to say when to come up. So now the waiting room is pretty empty because we're spreading out those visits. And we're starting a little bit earlier. We're going a little bit longer. We try and create a system that's very thoughtful, that keeps everyone feeling comfortable and that's safe. and conducive, to social distancing. So it's changed the way we've done, I think. And also, instead of our new patients coming in the office for the new patients or follow-up appointments, a lot of our visits are via telehealth. We're doing Zoom, we're doing call, and Zoom visits actually, it almost feels like a patient's in the office. You get a lot accomplished by that discussion. And it's actually a little better because if they're in the office, I can't see their face. Everyone's wearing a mask. So it's nice that, the patient, the partner, and it really feels like you're there talking to them in person, except it's like this, it's, via, Zoom. And I thought it was funny today. I had a patient follow-up, and it was her first Zoom, her first way of doing Zoom. And I asked her, I said, what did you think? She said, I like it. It's one of those things that sounds kind of weird, but once you give it a try, it works pretty nicely. You get a lot accomplished.
Great. And what about at the hospital, Dr. Blank?
Similarly, we're taking a lot of measures. There was a time where this is the last place you wanted to be. And now, of course, nobody wants to be in a hospital. It doesn't have to be in a hospital, but again, same measures are being taken. Everybody is wearing masks. If you're having any kind of procedure, there's testing that's done. People always ask, well, is the staff tested? At Mount Sinai, where we both work, the staff can have testing as much as they want for antibodies and things like that, but it's not a mandatory thing. Again, measures, there are fewer people around, there are masks, there's PPE everywhere. We take all of those measures.
Great.
Temperature checks at the door, sorry. Temperature checks all over the place. A lot of hand sanitizer.
Great. Dr. Blank, what do you think is the most striking difference about going to the doctor now versus before the pandemic?
It's really that waiting room, that empty waiting room, which is interesting. And just like Dr. Letterman said, we are starting earlier, ending later. We always wanted to have this method of reaching patients so they weren't sitting and waiting in the waiting room. Like you could text them to say the doctor's running late. Now it's actually happening. So I think that there are some things that are actually a little bit better. It's probably a little bit easier to get into the doctor right now because there is a lot of fear. So if you have been putting something off that you need to do, you can probably get in. But the empty waiting room and the templates are really very different. And as a result, we do have a bit more time with patients. I feel that that's working. And just like Dr. Letterman, you can get a lot done. And you're looking right at the person when you're talking to them too. It's very nice in some ways.
And so do you feel like it's safe to go to the doctor?
Well, I do. I think it's safer to go to the doctor than it is to go to the grocery store. Everything is enforced. We're wearing masks. So those things are happening. There are very strict rules for employees. If you have a fever, you stay home. So there aren't people out that have any kind of illness. There aren't people at work that have any kind of illness. So I do think it is safe to go.
Great. And then Dr. Blank, what are the specific considerations for women, for example, who need surgery for ovarian cancer or who need chemotherapy? There's those who are receiving other treatments, like they need to maybe go in for an MRI test. And there's also those people who have that history that are being followed up. So there's these different scenarios of different types of patients. Can you talk about that?
Yeah. So it's different depending on what you need. With surgery, early on in the pandemic, we couldn't do any surgery at all, and so we were using a lot more of what we call neoadjuvant chemotherapy for ovarian cancer. So we were starting most people, actually everybody, with chemotherapy first. Now, again, if you're having surgery, you will get tested beforehand. There are a lot of specific measures that are taken in the operating room to keep people safe as well. Surgery, we really want to avoid people having to be in the hospital for a long amount of time. We want to avoid people having to go to the ICU. So we are really taking those things into consideration when determining if somebody's a good candidate for surgery. And in some situations, if somebody was at extremely high risk for COVID, you might make a decision not to do surgery. You might look for a non-surgical option. For chemotherapy, first of all, we check everybody before they get chemotherapy for COVID because we would not want to give chemo if somebody had COVID. And the reason for that is because chemotherapy drops your immune system, and people who have a lower immune system or are immunocompromised do worse with COVID. So we've been very, very proactive about that. We use medications to avoid people from getting their blood counts from having them drop. And we've also changed some scheduling of chemos to avoid people having to come quite as much. There are some chemos that have specific effects on certain kinds of white blood cells, and we try to avoid those too. The ones that make the lymphocytes or the types of white blood cells that really fight viruses, we try to avoid those, the ones that are very hard on that. We did not interrupt chemotherapy because cancer doesn't know that COVID's going on. So, you still, we really just tried to support our patients and keep things as safe as possible for their treatments. I think the next question was for getting other treatments, right?
Yeah, like an MRI or blood work or any of that.
Mm-hmm. Well, we try again to make you not have to come as many times. All the measures are taken to try and keep patients safe. I think there's some question about, in terms of other treatments like immunotherapy or PARP inhibitors, other treatments that women on ovarian cancer are getting. And so immunotherapy is tricky because it can give you some findings in your lungs that look a lot like COVID. So there was some situations with that. It required a lot of education, and we were trying really not to start patients on new medications that could make things a little bit fuzzy as to whether it was side effects from treatment or COVID. The oral medications that can, we have to keep a close eye on people's blood counts, but we're able to do a lot of that via telehealth, so we can monitor that very well. For imaging, they're taking, the schedules are being managed so that they can clean everything a lot, and there are not full waiting rooms. So I think things are safe now. So when people, I'm sorry, I'm going on so much. For women being followed with cancer, that was a real tricky one because, everybody with cancer, most of our patients have had some sort of chemotherapy, and as a result, they wanted to avoid coming to having any exposure. And so people that had no symptoms, but were just coming for a visit because it was on their calendar, we did have them delay it. And I would say, depending on somebody's specific situation, her age, her other problems, we may still do that, may do a telehealth visit. But for anyone who's had a history of cancer and has any kind of symptom, I would highly recommend that they see their doctors. I mean, one of our concerns, I think, across the board, doctors taking care of women with cancer, that people are kind of ignoring symptoms because they don't want to go to the doctor, which I understand. But I do think it is safe to go to the doctor. If there's any symptom or concern, it's important to get it looked at.
Great, thank you. And what about cancer screenings? How should people be handling that, and what's the protocol at the moment?
Well, that's a great question. I mean, I think everyone's delayed their cancer screenings for at least 3 months now. For a period of time, they were definitely on hold. We may be in the sweet spot now because I do think it is safe now, and so we may have another hit. I do think that if you're overdue for cancer screening, it's very reasonable to go at this time. I mean, I went to the dermatologist today. I just figured I wanted to just tell you that. So I did a cancer screening today, so I'm putting my money where my mouth is. I think it's important. And actually, if you can get into a dermatologist now, which you can't usually, I think that's important to know. You can get that mammogram appointment if you can't usually, because nobody wants to do these things. But I do think, cancer screenings save lives, so do them now. I think probably like some of the more procedural things like colonoscopies are not probably up to the same regular volume as usual, but things that, here's another thing. If you're used to being really good about getting your cancer screening and now you're nervous because you put it on hold, I think it's better for you to get that screening than it is for you to worry that much more. I don't know. What do you think, Dr. Letterman?
I mean, I think, most hospital systems, have tried to come up with, a system that is, puts all patients at ease and keeps them, comfortable. And I feel comfortable. I've gone to the eye doctor myself, and that was a little while ago. And it's a different experience, going to the doctor. And, my kids have gone, to the doctor. I feel comfortable because there's so many precautions that are being taken to try and, create a safe environment, but also ease a lot of the nervousness. Everyone's nervous. It's very anxiety producing. And I know it's scary, but a lot has been done. And the viral load where we live now is it's the lowest in the country. So now's the time to, get back, to see the doctor and, do the screening visits because it's, very important.
Great. And what about women at an increased genetic risk for ovarian cancer? Would you kind of loop that into the part of the screenings that you were just saying, or any other additional advice for them?
Yeah,
Yeah,
I
so
mean, I think a lot women at increased genetic risk for cancer usually are on kind of an intense screening program. There are limitations to this screening that, we don't have the very best screening for women at increased genetic risk, unfortunately. So some of those, I think if a person, I was very comfortable with people delaying them for the 3 months that we've had. Again, I think you weigh risks and benefits. I think, the exam is probably a little bit the least important. Well, a breast exam is extremely important, but a pelvic exam is less important than some of the other things that we do. I think that the ultrasound and the CA-125 for ovarian cancer, although they're not proven, I'm just admitting this out here, I do think that those probably tell us a little bit more than the pelvic exam, but you can do the video visit so you can have the discussion, which is a big part of that interaction with the doctor.
Dr. Letterman, anything you want to add?
Yeah, so just, a little bit in terms of my, history. So, besides, being a fertility specialist that's part of RMA New York, personally, my wife is a BRCA2 carrier. And because of what I do for a living and, my family situation, I become very involved in the hereditary cancer community in terms of how does having, a hereditary genetic mutation such as BRCA, Lynch, affect, building and planning a family. So that's what I've got very involved to talk about what kind of fertility related options they have to ensure that they can build and plan their family appropriately based on what their current, situations are. And, those conversations can happen anytime, and what I'm trying to get out there is that anyone who's a BRCA carrier, who has Lynch, or some other hereditary cancer genetic mutation, I think they will benefit from reproductive counseling to determine how their carrier status affects the ability to build and plan a family. Because there's a lot of different factors that may influence how they go about it. Whether, how old they are, whether or not they're single or married, how big of a family they want, whether they plan to undergo risk-reducing surgery to remove the fallopian tubes and ovaries prior to either starting or completing a family. And also, women who have, a genetic mutation that predisposes them to cancer, they have the option of doing IVF, not only to check the embryo for chromosome abnormalities like most of our IVF patients do, but they also have the option of doing pre-implantation genetic testing. And, and that's because, women who have, this kind of hereditary genetic mutation, 50% of their offspring will inherit the gene. So these women have the option of doing the IVF where they biopsy the embryo to check for that specific mutation, to then transfer an embryo that's free of that mutation. So therefore decrease the chance of having a child with the effect, with that mutation. And in a way to end the cycle. And that may not be for everyone, but that's an option that some women consider when it comes to building and planning a family. And because of that, age is the most important thing when it comes to the success of fertility treatments. That's the most important thing. And for women who are committed to doing the IVF where they biopsy the embryo and do the pre-implantation genetic screening to screen out the mutation, it makes sense to try and consider those treatments, if that's what they're going to pursue, at an earlier age, because they're more likely to have success. And so because of all these factors and all these options, and it all differs based on their, situation, having the knowledge about what options they have may help them, build and plan the family. And that can be done in a telehealth visit. You don't need to be seeing a person to have that conversation. Those conversations could be had, with good old fashioned, Zoom. So that's what I've been trying to get out there and why I've got involved in some of these, hereditary cancer organizations to talk about if I'm what's called a pre-virus, I have the genetic mutation that predisposes me to cancer, what can I do to maximize my chances of having the family I want, and when, and what can we do to try and help them guide them along that path?
Great. And kind of on that note, then Dr. Letterman, what does an IVF cycle entail? We'll
So
start,
an
we'll start
IVF
talking more about fertility. There's a couple more questions. Perfect timing.
So an IVF cycle involves taking stimulation shots, which are tiny shots given the belly. And what those shots do is cause multiple follicles over to grow at one time. And we teach our patients how to do the shots. It's not as scary as it sounds. They're tiny needles. It sounds scary, but it's not as bad. And what we do is we follow these women every few days with early morning bloods and ultrasounds. These are quick visits in and out of the office. It's about 8 to 12 days of shots. And when the ovaries are ready, they take what's called the trigger shot. Then one undergoes what's called the egg retrieval 36 hours later. And that's done in our lab. We have an anesthesiologist, and patients receive IV sedation. So they're completely asleep. And while they're sleeping, using a vaginal ultrasound, attaching a little guide, vaginally puncture the ovaries into the follicles, and we take out the eggs. And then we'll cover our patients for about an hour or so, and they'll go home feeling sore and crampy. And then if someone's freezing eggs, we freeze the eggs. If they're creating embryos, we combine the sperm and eggs in addition. We grow the embryos out, and they can freeze embryos. Or if they're interested in, say, screening out a specific genetic mutation, and that can be done for almost any genetic mutation, whether it's a hereditary cancer genetic mutation, whether patients both have both cystic fibrosis carriers, we could biopsy the embryo and check for that. And then what we do is we grow the embryo out to an advanced stage, and then when we biopsy the embryo, we take a few cells from the outside of the embryo, which are cells destined to become the placenta, and then we freeze the embryos and send the cells to a specialized genetics laboratory to check for chromosome abnormalities, or in addition, for that specific genetic mutation.
It's fascinating, really. And Dr. Letterman, what's the difference between an IVF cycle and an egg-free cycle?
So an egg-free cycle in IVF, the start of it is exactly the same. And that's where they take the shots, which cause multiple follicles to grow. We monitor the response with the blood and ultrasound every few days. They take the trigger shot, and then they undergo the egg retrieval. So egg freezing and IVF, they start the same. For someone who's freezing eggs, we freeze the majority of eggs a few hours after the egg retrieval itself, or sometimes if they're initially immature eggs, or culture them in addition overnight and freeze them the following day. When someone's doing IVF, the day of the egg retrieval, we combine the sperm and eggs in a dish and then grow the embryos out.
Okay, great. What is PGD, Dr. Letterman?
So PGD stands for pre-implantation genetic diagnosis. So that used to be the term used to refer to the IVF procedure where you biopsy the embryo to check for a genetic mutation. So that's like the old terminology and old nomenclature. Now they've changed, the terminology, and the newer term for that which is the exact same thing, is PGT-A, which stands for pre-implantation genetic testing for aneuploidy. That's checking for chromosomes. Okay. PGTM is pre-implantation genetic testing for monogenic disorders, which is a fancy term for saying I'm testing the embryos for their specific genetic abnormality. So someone who's a BRCA carrier who wants to screen out the mutation, they're doing what's called PGTM. So a lot of patients, when they talk about it, and a lot of people in the medical profession would talk about PGD, which they changed the nomenclature. It's a little confusing. So it all represents the same thing. It's just a different way of describing it.
Okay. And what about if someone had both their ovaries removed? Can they still carry a pregnancy if they have a uterus?
So I get this question all the time, and a lot of women are not aware that you don't need ovaries to carry a pregnancy, And so for women who, whether they have a BRCA or Lynch, or say they're having a risk-reducing surgery to remove the fallopian tubes and ovaries, one thing we could do is freeze their eggs or embryos, before they undergo the risk-reducing surgery. And then for them to get pregnant in the future, they just need the uterus. And we give them hormones to support their the lining prior to an embryo transfer, and then to support an early pregnancy before the pregnancy takes over. So one doesn't need to have ovaries in order to carry a pregnancy. And a lot of women are not aware of that. They always thought that they need ovaries to carry a pregnancy. You need a uterus to carry a pregnancy, but not necessarily ovaries.
Okay, great. So we've got a lot of questions, and I'm going to kind of bounce around on some topics now. So can you tell us, actually, if you could speak a little more about colonoscopies? I know that was mentioned earlier, but is it safe if someone needs a colonoscopy? Maybe they're symptomatic and being asked to go get a colonoscopy. How would you advise someone to deal with that? If either one of you want to take that.
If someone were symptomatic, I would tell them to get the colonoscopy. I mean, I do think it's safe to have procedures done now. I think it's safe in the hospitals, and I think it's less safe to let something kind of sit there and brew. I think it's important to get the medical care that you need now.
Okay, great. And what vitamins do you recommend taking to improve embryo quality? What are your thoughts on acupuncture and embryo quality?
So that's another common question we get to, a lot of patients like to say is any pill or anything I can do to make my ovaries better, to create better embryos? And the unfortunate thing is there's no magic pill that, improves one's fertility. There's a lot of stuff out there in terms of certain supplements, but when they do all the studies, none of them, demonstrates an improved chances of, them getting pregnant. So there's no magic, pill. When it comes to acupuncture, they've done a lot of studies looking at acupuncture in terms of success rates. And we have tons of patients who do acupuncture. But what they, and the theory is, that they may increase the blood flow to the uterus, the ovaries, to improve, outcome and response. But the studies, they don't show any difference in terms of outcomes. But what acupuncture does do, it helps reduce stress. So it acts as a nice stress reducer. So we have tons of patients who do acupuncture, but I always tell them, I can't say it doesn't improve outcome, but it may help make the process a lot, easier, more palatable. And, the only downside I tell them is, just one more thing you have to incorporate into your routine in terms of how to figure out how to do and any cost associated with that. But a lot of patients will use acupuncture as an ancillary procedure, and it does help make the process a little bit easier. Because it's, fertility, infertility is a stressful process, and that's one thing that may help reduce the stress.
Okay. Can you guys speak more about the telehealth appointments? So, like, for example, what screenings can be done via telehealth, and then what would warrant someone to need to come in for an in-person visit based on, that telehealth meeting?
So a lot of, when we think of screening tests, a lot of them we think of are things like, pap smears, mammograms, colonoscopies. Obviously, those things can't be done via telehealth. But the things that can be done via telehealth, for example, T.E.A.L does it. One of T.E.A.L's big things is making people aware of the symptoms of ovarian cancer. So, one of the things that I do, when I'm seeing a woman at increased genetic risk for ovarian cancer or endometrial cancer would be to ask about those things. So you can do that 100%. You can do just as well via telehealth as you can, in person. Now, if, when you're talking to your doctor about the symptoms, the doctor might say, you need to come in. I mean, the other thing you can do, I guess you're asking, when do you need to come in? You can say, if you're very nervous and you feel that having someone lay their hands on you would be helpful, I would express that. But otherwise, you can certainly have a telehealth visit and your doctor and you can decide together that you need to come in. Something like abnormal bleeding, I think, is something that probably warrants an in-person visit. When you're talking about the symptoms of ovarian cancer, I mean, you're an expert on this, you spread this word, but I mean, things like any kind of symptoms, bloating, bowel changes, pain, urinary changes, things like that, everybody has them, but if they stick around for more than 2 weeks, you probably do need to be seen. Is that your messaging as well, Pamela?
Absolutely. Yeah. Yeah, I was going to actually you took the words out of my mouth about the symptoms.
Sorry.
No, it's fine. But that's, the importance of ovarian cancer, just the reminder to everybody today, there is no screening test. So, even if you do go to the doctor, this is one of those diseases that really slips under the radar. And, we do our best to get that diagnosed, but it is a challenging disease with no test. But there's symptoms, there's signs, there's risk factors. I myself have a high risk. I did get genetically tested after my sister Louisa got ovarian cancer. we started this foundation together, Tell Every Amazing Lady, and her doctors asked me to get genetically tested, which of course I did because they said it would help her and figure out her treatment options, and found that I have something called Lynch syndrome. So I fit into the high risk category, and I need to keep up with my pelvic exams and my sonograms. I actually had a mammogram during quarantine and I felt very safe. I did go to a facility and I really felt safer than the grocery store, like you said. It's just everyone's in like space suits and you're not really touching anybody. But really about ovarian cancer, you know, the 2-week recommendation, if these symptoms are persistent, you can always reach out to our foundation, talk to your doctor. But it's really important to understand, you know, it's one of those diseases that are a little bit vague. Who doesn't have back pain once in a while? And what woman doesn't get bloating maybe once a month? So if it's lasting longer, you should get it checked out. Genetic testing is something that we want to talk about a little bit too. Can you guys give advice on, you know, who should get genetically tested? I'll start off by just telling a little more of my story, where my sister, when she was diagnosed with ovarian cancer, we actually didn't have any ovarian cancer in the family, but we had other cancers in the family. We had colon cancer. We later found out uterine cancer. And so the ovarian cancer kind of came out of nowhere for us, but we did talk about our family history together after her diagnosis. Her doctor asked us to get tested. Myself, my father, other family members got tested, and all of us have Lynch syndrome. And Lynch syndrome is something like BRCA, but it's just related to colon cancer, uterine cancer, and ovarian. So there's things that are recommended for people who carry that mutation to, you know, see their doctor more regularly and have certain screenings. But if you guys want to add to that and any other advice or protocols you want to suggest to people.
Sure. So, you know, who should get genetically tested? I think, you know, you look at your somebody's personal risk and then their family risk. So if a woman herself has had ovarian cancer, she should definitely get tested. Other things, pancreatic cancer, men with prostate cancer should get tested, as well as women who have certain types of breast cancer very young, or breast cancer on both sides. But then when you're thinking about your family history, just a couple of things, people sometimes don't realize that, you know, a gene that predisposes them to a gynecologic cancer can come from their father. So you need to look at both your father's side and your mother's side, just as you alluded to. And it's also very important to look, you know, a little bit further than you might think. You need to know not only about just your parents, but the grandparents and aunts and uncles and such, because everybody who has a mutation might not have a cancer. So you can have a mutation and not get cancer. So even if, you know, if you have a grandmother and an aunt that have cancer, but your mother doesn't have cancer, that doesn't mean that there's no mutation in the family, for example. So you look at the whole family tree and figure it out. I mean, the best way to figure out, you know, is to speak with a genetic counselor. And speaking of telehealth, you know, telegenetics are wonderful because they can do the whole thing this way. I think it's going to really revolutionize the field. To get the test done, it's generally either a blood draw or sometimes it's a swabbing of the cheek. But usually here we do blood draws, so that you would need to go to a place to get your blood drawn. Anything you want to add to that?
I think you hit on, you know, some really important points, but two of the things I think that a lot of people don't think about is that these, you know, gynecologic cancers, that gene could come from the dad, from the male side. And a lot of men are not as familiar with that. And so that's why it's very important when taking a family history to ask about, you know, their, like you said, the aunts, the uncles, the grandparents, you know, a little bit of the extended family, to get, you know, what specific type of cancers, because certainly these cancers cluster together, and it could be all, you know, they could be transmitted from the male. For BRCA, you don't necessarily think about, you know, men and BRCA, but remember, they still represent a big portion. And yes, you know, they have less risk of cancers. You know, there's the risk of, you know, prostate, you know, male breast and pancreatic, but their daughters, you know, 50% chance of their daughters will inherit the gene and therefore have the increased risk of breast cancer, ovarian cancer, pancreatic, skin cancer. So it's a very important to not neglect that it could come from the you know, male side. And the other thing that I think, you know, Dr. Fleck said is very important, that if there is a cluster of a family history, it's best to speak to a cancer geneticist, and, you know, where they could go even further into the history and do the testing. And one of the things that I think is going to come out of this pandemic is not only are we doing a lot more telehealth, but where I think it really is going to help is the geneticists. Because a lot of that used to be done in person. I think they're now going to be transforming more to telehealth visits because they don't need to be done in person. And that will allow, the opportunity to be more available to others who is not as convenient, who had someone who maybe specialized in cancer genetics. So we'll give them more an opportunity to have the conversation, see if it's worth them being tested, and then doing the test.
Okay, great. We have a question. I'm going to try this word. Can mesiosism in the embryo be a symptom of ovarian cancer? Did I say that right?
So, it was a good try. It's a funny word. It's called, the word is mosaicism.
Okay.
So mosaicism is a controversial topic in the fertility world. And what that first means is that, so when almost all our patients we do IVF, like I said, we're biopsying the embryo, checking for chromosome abnormalities. Things like Down syndrome, which is trisomy 21, as well as numerous other chromosome abnormalities. And when you have a chromosomally normal embryo, at least in our program, it will then implant 60 to 70% of the time. So it allows us to transfer one embryo with high confidence. We're not transferring embryos that were destined to fail from the start or ones that are destined to miscarry. Even though this doesn't completely eliminate miscarriage, it greatly reduces it. And then you know exactly what you have in terms of your embryos. So that's what our patients, when they do IVF, we biopsy the embryos for chromosome abnormalities. And where age plays a role in this, the older one is, the harder to get to that chromosomally normal embryo. So that's where age plays a role. But regardless of age, it works the same. Screening equalizes everyone. So one of the uncommon results of an embryo biopsy, which happens maybe about 5 to 7%, is where you get a result that's called mosaicism. And that's where some of the cells of the embryo are chromosomally normal, but some are not. So it's like a mix. And there's a lot of controversy in the fertility world what to do with those embryos, So usually we don't recommend transferring them because we don't know a lot. There hasn't been enough studies looking at the long-term outcomes of those children who are born from that. So there've been some transfers and there've been some babies born through those transfers, but there hasn't been enough follow-up studies to track them to see if they have any long-term issues. So for those reasons, we're a little squeamish using them, but there's different specific abnormalities. So that's what mosaicism is. And we'll know more about what to do with those embryos in the next few years as a further study. And just going back to the question, you said ovarian cancer, does having mosaicism increase the risk of ovarian cancer, or what was it?
Is it a symptom of ovarian cancer or increase the risk?
So I don't believe it is. I can't say that there's data to say that someone who makes more mosaic embryos, for some reason, they're more at risk of cancer. There's not enough data. No one, I don't think, has looked at that. But I don't suspect that would be a reason. Because we see that for a lot of patients, not a lot, but about 5 to 7% of embryos that get biopsied will show that. So I don't, I can't say that based on data, but just based on, biologically, I don't think someone who has mosaic embryos may be more at risk in the future for developing ovarian cancer.
Okay. And then can you guys speak about the recurrence of ovarian cancer? So the questions, there's kind of a two-part question I'll combine. Does ovarian cancer recur? And as someone approaches their 6 years of remission of ovarian cancer and peritoneal cancer, wondering if there's a likelihood of recurrence.
Sure. So unfortunately, ovarian cancer can occur, and depending on the stage, it oftentimes does recur. In fact, most of the major advances that have happened in ovarian cancer, though, are treatments for when disease comes back, or newer, actually, treatment, something called maintenance treatment that can be done at the beginning that we can hopefully prevent recurrences. So we're really working on that. So the first question was, does ovarian cancer recur? Well, oftentimes it does. It doesn't always, though. And for the person who's out 6 years, you've already gone longer than most people will without recurring. So numbers do not matter for you. I would say that you've done very well. I think you should still consider, continue to have your follow-ups. I saw a woman, one of my patients last week, who's been 20 years without her cancer coming back. And you would never tell people that that's a likelihood, but it can happen. And we do think that for some people, it will happen. I think it's very hard when you have ovarian cancer to be done with your treatment and then worry about that all the time. But we're following people very carefully. And again, we do have much better treatments should something come back. This person that's 6 years out should be very happy. That's very
Yes,
good. Yes.
I agree. That's exciting.
Yeah.
We honor that person.
Yes.
How are genetics involved in the fertility process, and what kind of genetic testing could someone get?
So when fertility now is all about the genetics. It's, genetics is, become a huge portion of fertility treatment for a few reasons. Number one, anyone when we see them in the office, we recommend this doing an expanded carrier panel. And what that is, it's a platform that's looking at, things like cystic fibrosis, Tay-Sachs, as well as numerous other carrier states that you can't even pronounce. And, there's one platform evaluates 283 mutations. And when you do this fancy test, 70% have something, and the key is you don't have the same something, right? So God forbid you had 2 cystic fibrosis carriers, 2 couples with Tay-Sachs, they would then have a 1 in 4 chance of having a child with the affected disorder. So those couples have the option of doing IVF, where you biopsy the embryo to screen out that mutation so you don't have a child affected with disorder. You could pick an embryo that's not affected. You could transfer a carrier embryo, but not one that's affected. Same kind of concept with the cancer genetics, but with the cancer genetic mutations, 50% will inherit the gene. So there's a much higher rate, So we're able to prevent diseases, by, doing the carrier screening and finding out before they're pregnant. When couples do the carrier screening, like I said, we usually do this at the first visit or shortly after. It takes a few weeks to get the results. I think about 3% of couples, I think it's about 2 to 3% will test positive for both being a carrier for the same thing. And some of those have really devastating effects to the children, and we can prevent, disease. And then, like I've been talking about before, almost all our patients, when we're doing IVF, we're biopsying and checking the embryos for the chromosome abnormalities, and then transferring a single chromosomal abnormality. And therefore, we don't see any more twins. In this, we hardly see twins anymore. Once in a while, when we put back an embryo, it gets split into identical twins. That's about 2%. So I see when that happens, there's a lot of surprise faces because obviously it's very unexpected. Especially maybe if they're coming for baby number 2 and they got 2 and 3. So we don't see it that often, but we barely see twins because when you screen the embryo, it allows us to pick the best embryo. And, we transfer the one embryo, we prevent failed cycles. We don't see hardly twins anymore. And, we're also able to, keep those embryos remain frozen. They don't age. So we're able to, have their future, if they want future kids. And I've got to mention, it helps prevent miscarriages, and sometimes we see women, not only just for fertility, but for, I get pregnant, but I have a lot of miscarriages, and it's just keeping the pregnancy. And the most common cause of miscarriage is that it's destined to fail from the start because it's chromosomally abnormal. So for those cases, we could do IVF, check the embryo for a chromosomally normal embryo, and then transfer a single embryo to help prevent a miscarriage. Once it doesn't eliminate it, but it greatly reduces it. So genetics, plays a huge role in fertility for multiple different areas that I just mentioned.
Great. If someone wanted to get genetic testing, what doctor would order that? So do they go to their primary physician? Do they go to their OB/GYN? Where would you guys suggest that they start?
I think if somebody knows they have a mutation in the family, it depends on the situation. I think speaking with your doctor first, both a primary and an OB/GYN can order it. I think in an ideal world, it's not just an ordered test, but it goes along with some counseling, a discussion, because there are a lot of different tests that can be ordered. So in an ideal world, the doctor would refer you to a genetic counselor who could order it. Alternatively, you can get the testing done and then have genetic counseling on the backside if you have positive findings. But it's a little bit tricky because even if you have a striking family history but a negative, genetic workup, that doesn't mean that you have no genetic risk. So I do think it's important not to just, do 23andMe and find it negative and say like, woo, I'm good, I'm done, because the results are a little bit more difficult to interpret.
Yeah, and I would add that we also have resources at Tell Every Amazing Lady. There's sometimes clinical trials for genetic resources. There's workshops and webinars that we can help answer questions as well. So if anybody
Great.
wanted further information, they can come to us if they'd like.
I just want to piggyback on what Dr. Blank, said. Two things. I agree. I think, in the ideal world, it's best sending to, a geneticist. If there's a cancer geneticist, because they could pick, the right panel. It's not just about testing for, say, BRCA or Lynch. Now they're doing these expanded cancer panels. There's multiple genes, and if it's just being ordered by an OB, a primary doctor, they may not order, the appropriate expanded test. So they may test negative for, say, BRCA, but they could have something else. So going through a geneticist who could, properly counsel pre-testing and post-testing what it means, I think that's the best way to do it. It's not always as, easy to go that route, but hopefully now with telehealth, that'll make it, easier and more available. And the other thing you mentioned about 23andMe, we see a lot of patients who come, oh, I did 23andMe, I'm all good. And, 23andMe is only testing for, say, they actually test for BRCA, but it's only a few of the mutations, not all of them. So a lot of them are missed. And then also when it comes to other, they test for some cystic fibrosis mutations and other, carrier mutations, but only a subset. And they're not being sequenced like the more fancy panels are doing. So 23andMe, yes, you can do it online. It sounds like you get a little information, but it's, it's a small chapter in the whole book. It's not an expansive way of doing it. So I think that's important to bring up, 23andMe.
Yeah.
Because a lot of people like doing that now.
Yeah. And I would never have, say, risk-reducing surgery based on a 23andMe result. I would always have that, looked at, speak to a genetic counselor, get a proper test, just like what you were saying. Yeah.
I agree. And I would add that I was tested by a genetic counselor back in 2007, and that's where I learned I had Lynch syndrome. But since then, so many more panels have come out. I actually got retested and found that I have yet another gene. So I have BRIP1 positive as well. So that's why I got my mammogram.
Yeah.
But yeah, I mean, there's so many panels. Just make sure you guys are going to, a doctor as best you can, and sit with a genetic counselor if you're able to. Let's see. So we got a question about clinical trials in ovarian cancer. How do I get involved? Dr. Blank, you want to answer that?
Sure. So clinical trial, I'm so glad you asked that question, because clinical trials are a great way to get the most current treatments and to advance science. And the reason that women are living longer today is because with ovarian cancer is because women have participated in trials. So great question. I think one of the best ways to find out about trials is to work with someone like what panelists like with T.E.A.L. I think that going to if you go to clinicaltrials.gov, it is very overwhelming. So I do think since you're watching this, about this. You can go to T.E.A.L. and you can get a clinical trials. It's literally clinical trials navigator, what you serve as. I think that's a wonderful thing to have access to. So that's I would say that's the best way. If you for some reason cannot, you can ask your doctor to help, but it really would be smart. Ask your doctor what he or she has available at their institution, but otherwise I think it's important to look a little bit more broadly, because there's a great variety of trials.
Okay, great. Okay, for a strong family history of breast cancer, premenopause, is there always or also an increase in ovarian, uterine, and other cancers?
Well, I think if there's a strong family history of premenopausal breast cancer, I think a panel test would be indicated. And no, because some genes have different other cancers that are associated with them. So I think that for example, there's a gene called PALB2 that's really more associated with pancreatic cancer and breast cancer. So I think that's a situation where you would want to get the gene, find out the exact gene, and then you can get some more specific recommendations. Again, you may get tested and find it's negative, and then it's a little bit harder to give you any kind of numbers as to your risk of cancer, but it's still probably worth doing.
And then follow up from that question, any other tests that should be done for precaution? For example, for a pelvic exam involving like a follow-up, what time of the month is the best time to do those types of exams?
Sure. So for ultrasounds, the best time to do the exam for somebody who is still having periods is day 5 to 9, because that's the least likely time then you're going to find things that are just there because of function of where you are in the cycle. So if the day 1 is the first day you get your period, so day 5 to 9 is the best time to do it. You were asking if you do have some sort of different genetic mutations, it may change your screening a little bit. Sometimes, for example, a breast MRI is indicated, not just a mammogram. So it does vary depending on the mutation.
Okay. So we have about 5 minutes left. We have time for maybe 2 more questions. So someone who is adopted and doesn't have that family history, how do they approach screenings at almost 40 years old?
So it's tricky when you're adopted because you don't have a family history to go on, and I wouldn't overscreen. I think if in that situation, you probably would want to be screened the same as the general population. So, you know, you'll be getting a baseline mammogram. You're young for a colonoscopy. You should see your gynecologist to do the regular screening.
Okay. One of the questions I see we get a lot of is about neuropathy. It's definitely an ongoing problem for a lot of women who've had ovarian cancer and gynecologic cancers. So is there anything that you guys are aware of for any new treatments, new findings, new studies, anything that would, you know, help anybody out there listening that has neuropathy?
Yeah, neuropathy is really rough. You know, I think first of all, there's a couple of different things that can be done. I mean, you're talking about once you already do have neuropathy. I think, you know, nothing has been definitive or been the big aha moment in terms of studies looking at neuropathy. I think we've had some people do well with physical therapy or acupuncture. I don't think there's evidence to support that. You know, there are some medications that people take, some vitamins, glutamine and B6 some people take, but these things don't always work. I think if somebody's getting chemotherapy and they're starting to notice any symptoms like this, it's very important to report those symptoms because doses should be dropped a little bit so that you don't end up with the long-term consequences. So it's very important that people feel sort of empowered to report that. It's really, I think learning a lot more, you know, if somebody is 6 years out from ovarian cancer but can't button her shirt, that's an issue. So I'm sorry to the person with neuropathy.
And I think we have time just for one last question. What supports are available for emotional burdens or any kind of trauma associated with fertility challenges and treatments? What kind of advice or support can you direct people to if they're struggling with that?
So, you know, the fertility journey, it's very stressful. You know, it's stressful for both the patient, a partner, and so it's like a lot of times it's like a roller coaster. There's some highs and lows, and because of that, having a support system, set up makes it a little easier, you know, during the process. So there are certain organizations like Resolve, which is an advocacy group for women and men with infertility. They're in an amazing group. They're online. They have support groups. They involved in supporting research. They were very involved with getting fertility and IVF coverage for New York that went into effect this year. So that was a huge. They were a huge part behind that. So Resolve is a great organization with support groups, and now with everything being online, there's a lot more online support groups. And what we do, at least in our program, we have a fertility counselor that's available to all our patients at no cost, where they could talk, via email, phone, in person, although it's less in person now, virtually, because it is such a tough process. And, having that support in those groups makes it easier, letting these women and men know that, they're not alone. Fertility affects 1 in 8 couples. It's more common than women realize. And, many years ago, not everyone would talk about it. Everyone was more private. But now with being able to connect online, there's tons of groups that are out there. There's tons of forums, to talk about these things. Like I said, Resolve is a great organization. So at our program, we have a fertility counselor to help support them through, the difficult journeys.
Well, I think that's all the time that we have. Thank you so much. Thank you to RMA, Dr. Letterman, Dr. Blank for answering everyone's questions. And I just want to remind everybody that this is being recorded today, so it will be available through RMA afterwards. I'm sure you get an email and can share it. So thank you. Thank you so much, everyone. Have the great rest of your day.
Thank you so much for the opportunity. Thank
Thank you,
you.
everyone.
Thank
Take
you.
care.
Bye. Stay safe.